So, hello everyone. We once again meet on this fine Sunday regarding the Otology webinar series. We have started this exactly 5 years ago during COVID lockdown, and uh, luckily the program our first webinar was also on cochlear implant candidacy criteria, and it was a series of webinars. By Dr. Manusmith and Dr. Satyakiran sir from Hyderabad. And we also are very happy and fortunate to have them on this panel today. Today's topic, I would like to introduce the speaker, Dr. Manoj sir from Calicut. He has done his MBBS from Madras University, Chengalpattu Medical College, and MSc ENT from Madras Medical College. Worked as a lecturer and assistant professor in Trichure and Calicut Medical Colleges. Then he has started his own center called the Messiarch ENT Institute in 2006, and is one of the best equipped ENT hospitals in his part of the state. And Sir has a very huge series of pediatric cochlear implants, almost over 3,000 implant surgeries, and one of the largest series of bilateral cochlear implant program. He was also instrumental in forming the guidelines and structure of Kerala government state cochlear implant scheme, and it is one of the finest government program all over the India. And he's a member of Hearing Group, which is an allied group of 28 centers around the world, which uh, which engage in research in otology and neuro-otology. And he has been invited as an speaker and operating faculty in various centers worldwide. And he has, to his credit, numerous publications in various journals. And we are very fortunate to have him on our platform. So the topic for today is building a strong and sustainable pediatric cochlear implant program. And I request Sir to take over and begin his lecture.
Hi, so good evening, and thanks for coming here on a Sunday, because generally Sundays we are not supposed to be working, but I think he has made sure that all of you are here. So thanks a lot, Shreyasha, for inviting me, and I'm glad that Manusmith and who else you said was moderating this? Manusmith is here, and
Dr. Satyakiran, yeah.
Satyakaran. Oh, both of them are very well known to me. So I think from what I hear that there is a large amount of the people here are today are postgraduates and residents. So I think my focus of my talk will be mainly directed towards them and not to the consultants. So we are talking about how to build a strong and sustainable pediatric cochlear implant program. You must understand that I'm not going to go through much of radiology and surgery and all that you're going here, that they are used to in cochlear implant talks. But what you will here learn is that how to build a pediatric specific team structure and how to have a child-friendly infrastructure. It has to be child-friendly, and how to do early identification through habilitation, how to create family-centered efficiency strategies, and how to measure your developmental outcomes and quality metrics, and how to sustain this. I mean, it's not only important. So if people come outside, they pass and they suddenly say, oh, I want to start a CA program. You often hear about these things. I know people start, and then after some time, many of them, we do not know what's happening. So it's important thing is to know how to not only to start it in a good way, but also to sustain it. Now, why do pediatric CA programs matter? Because if you know that, see all programs all over the world, which are the successful ones? The successful ones are the ones where they actually implant them before 12 months. And there should be a very low failure rate. You should have less than 1 to 2% of failures in surgical, in pediatric cochlear implants. And if you do implants between that, ideally between 1 year, but even if you go maximum maybe 18, 24 months, you will get good results. And beyond that, you're going to get really poor results. It's a difference of day and night. It's only when you do that early will you have early language development, the school readiness, they do well in school, they have academic successes, they integrate with hearing peers, and of course, there is a family life with bonding. So this is very important why pediatric CIS cochlear implant programs matter. Now listen to this video of this young girl who actually is much older now. This is many years back, and she gave us a message on World Hearing Day. So she is Amaria. She was implanted very young, both years, and listen to what she's saying.
Hi, I am Maria Prince. World Hearing Day is on 3rd March. May I tell you something? I can hear everything through the cochlear implant. Identify hearing loss before 2 months of age. And start treatment. Every child can speak like me then. Thank you. Bye.
Now, if you look at what Amri has said, many things. Identify hearing loss by 2 months and do implants early, and every child can speak like her, and she could not be more correct. I didn't tell her what to speak. I just said that and called her mother and said, make something to do with early implantation, and that's what she did. And this is so important. Look at the tone, look at how she speaks, look at how she says bye. And these are things that are important in developing good speech and language after cochlear implant. So what is the challenge when you see this? Now there is, of course, there is a late identification despite newborn screening. This we see it in Kerala. In Kerala, we had a lot of children who have been identified early, but still they are now not actually going through that process where they are evaluated. There is a delay. I mean, you identify and then there is a long gap before something happens. Families don't make decisions early enough, and they do not have access to specialized pediatric care centers. Look at this boy. I mean, you know that Kerala is a very educated state, and he's talking in Malayalam, but you will generally understand. What is going to happen is that I'm going to ask him certain things, and he is answering. At the end, he says A, B, C, D, Z to Z. Now, this boy was having not a bad degree of hearing loss. In fact, his hearing was much better than the girls, Amriya, that you saw earlier. But you can ask him, if I ask him familiar things, he answers. If I ask him non-familiar things, he's completely clueless. Listen to this. I'm asking his name. It's only when I'm shouting at about 8 I ask him what school. He says 8th standard. And then he says the school. I'm asking him to come to 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
A B C D Z വരെ A B C D Z വരെ. I'm asking say A B D Z.
A B C D E F G H I J K L M N O P Q.
So now if you listen to him, you can see the exaggerated lip movements that are often taught in children who have speech therapy when they are profoundly deaf. He says O and all with the mouth forming an O. And this is actually you're visually reading speech that is not actually coming from inside. And this is what you don't want to happen. This boy, not a profound hearing loss, only severe hearing loss, given a hearing aid. But when he comes to you like this, and whatever you do, his speech is never going to improve. So what do you need to have a sustainable program which makes a girl like Amriya, not somebody like this boy? You need a pediatric ENT surgeon, you need a pediatric audiologist, you need a pediatric speech and language pathologist, you need a child psychologist, educational audiologist, early intervention specialist, family support coordinator, pediatric nurse, and of course insurance navigator, which of course it is. We have all this. Okay, by the way, we have our own team in ENT surgeons, and we have 6 ENT people, of which me and 3 others do CIs regularly. We have 8 pediatric audiologists. We have 8 AVT specialists. We have tied up with the child psychologist, and we have family support coordinator, because we have a whole set of pediatric nurses and pediatric anesthetist, and we do have an insurance team. So all these people together make a program. So if you are wanting to start a serious cochlear implant program, you need to have this team there. Without this team, nothing is going to happen. You cannot, as a surgeon, however good and intelligent and brilliant you are, can start an ENT program and pediatric CA program just based on your merit alone. So we tied up with this group, with the center called Astria. The lady here, she is a physiatrist. She is married to my junior who does CI, and they actually deal with cerebral palsy, autism disorders, and they have. So what we do is we send our children there, and they get them evaluated and show up the red flags. In these red flags, we'll assess that before actually suggesting a CI, and this is done very, very early. You need to have also child-friendly spaces. You need to have playroom with age-appropriate toys, family waiting areas. So we have a separate center which handles habilitation. It should not be inside the hospital. children don't like hospitals. I mean, you have to be very sure about that. You need a separate center. I mean, of course, it could be in the same campus, but should not be within your OP. And it should have pediatric sized equipments and furniture, and you should have hospital records to monitor these things and also to schedule their treatment. So this is how you need to have. You should have a center. You should have play therapy, a lot of things to do and to find out. Now, see, look at this video. So we have a child who's implanted. We have our therapist. Her name is Jilsha. She's brilliant. And they are actually doing a small play acting thing. You know, it is they're having some vegetables and fruits, and this is a real scale here. And she's teaching him what to buy. They're wearing masks. Baby, I want green grape. He says green grapes. She says it is sweet, and the boy says, yes, it is sweet, and he measures it. So we have all these things that happen. So you need to have these kind of play environments where they love playing. So therapy is not somebody sitting in a chair and being taught. They have to understand that this is enjoyable, because if it is not enjoyable, they will never learn properly. So the whole pathway is not only about all these things, should be about newborn hearing screening, language play, audiological evaluation, surgery, and going for therapy. So the pediatric CI journey goes along these 5 steps: screening, intervention, candidacy, surgery, and habilitation. And all these things together form what is a good CI program. So what is the timeline? So by the time they are 1 month old, they need to have hearing screening. By the time they are 1 to 3 months old, they should have the hearing aid fitted. And by 3 to 6 months, they should be regularly having therapy. And by 6 to 12 months, they should be having a cochlear implant. Now, you cannot have somebody coming to you at a year and a half and saying that my child is not speaking, and then do a CI, and then find out that they don't do well enough. So, I mean, if there is a young person out here, I mean, I'm sure there are a lot of people who want to be doing CI. What you should be doing is that you should be setting up a center, which could be a hospital or wherever, and then making sure that you talk to the pediatricians and gynecologists and ask them to send children very early. Now, your therapist, I mean, you have to test the hearing, because it takes time for an audiologist to do ideal hearing testing. I'll go through that very soon. And make sure that you're able to diagnose deafness positively by the time they are 3 or 4 months of age. I mean, you don't have to do CI for all of them. This is a big mistake. People think, okay, let me do a CI immediately, I get one hold of one patient. So what you need to do is that you need to actually send them to an established CI center. It looks very crazy that I'm saying this, but and then because you cannot, nobody will come to you directly. You might get one patient, and I mean, you may not get the second patient. So you send them to a good CI center, but ask them to come back to you for therapy. But don't send the children who are 60, 70 dB hearing loss. They don't need a CI. So you do habilitation for them and they get better. Slowly, you'll have a batch of young children with you who are about 60, 70 dB hearing loss, but hearing it fitted very early, developing good speech and language. And you have these few who will go outside, have implants, and come in. And there won't be a qualitative difference between these two. A child who's been given a hearing aid at 3 months having 70 dB hearing loss, child having a CI at about 10 months will look the same. And then they will understand that, okay, this place is good. There is habilitation happening here. Now, why don't I do surgery here itself? The need for surgery must come from the patient. You should not something that, okay, don't go there, I'll do it. That's a very wrong way of doing things. And because of this, the Joint Committee in Hearing has come up with not this 136 rule, but a 123 rule. This is what is actually said. They say that if you can, it's okay. If you are beginning, you could have the 136, but now it is actually 123. You need to have hearing screening in 1 month. You need to have an evaluation in 2 months, and you should have hearing aid fitting by 3 months. So it is okay to have 136 because there's a basic minimum that is required. But for a center to really grow, you should cut that down to 3 months of age. See, I do not know whether you know of this girl. She was last year, she was in the WHO list of the world hearing year, in the WHO year of deafness, and she was a WHO girl. Her name is Rizwana. She finished her MBBS. I had implanted her when she was very young in flying colors. And now you know what she's doing? She joined MSc ENT in Calicut Medical College, which is very near. I come from Calicut. Now, this happens. I implanted more than 20 years back. If today I could have a surgeon, an MSc ENT surgeon passing out from a reputed institution in the state, it is because our program started 22 years back in a manner that will make them become like this in the future. Our focus was clearly not to do a large number of implants. Our focus was to do implants for the right children at the right time. I tell you why this is important. So I'll tell you about two stories of these two children. When we were doing implants, it must have been around 2003 or something. Both these girls were bought by their parents to us. They were about a year and a half of age, and they all had residual hearing. So we told them, okay, I mean, your child will speak without a hearing, without a cochlear implant, but the speech will never be normal. You need to have a cochlear implant. Now it is very difficult to convince them. The one child was a doctor's daughter, other was an engineer's daughter, and they all said, okay, this child is hearing, the child is responding with a hearing aid. My therapist said that don't do a cochlear implant and all that. I said, okay, you make a choice. So they went to a habilitation center, and then they were having therapy there. And when the engineer's daughter came back to us, she came to us when she was 4.5, and these are children with residual hearing, and you can't compare this to a child who was profoundly deaf. And she actually started speaking like this, and we eventually did a second year also.
Hi, I'm Rose P, and this video is about my experience of using bilateral cochlear implantation. I did my first implant on my right side when I was 4 years old, and my second implant on my left side when I was 18 years old. And to say this experience, it was really fabulous. It's just that when I was using one side alone, I wasn't realizing what I was missing out. It's like when I did my second implantation, I had like a completion of hearing, and I could manage with both ears if any unpredicted situation, like for example, if you're in a meeting or if you're on a call with someone, suddenly if one side goes off, I can manage with the other side. And even when situations like, I suppose when I'm driving, I really love driving, and I had when we were sitting on the right side and driving, and at that time when I was using one side hearing, it was really difficult for me to travel with another person on my left side. It was like I really hated traveling with someone on my left side. I would prefer solo drives. But now when I did my second implantation, it's like I could easily mingle with people. I could easily understand what they were saying on my left side.
So this is how she's talking about a second implant. But you can see that her speech is not the perfect good speech, but still, because of residual hearing, even when we implanted 3.5 years, she still has got good. These are children with residual hearing. I mean, this is what I told you about. You need to pick up these children very young. But the other child, the doctor's daughter, she came to us very late. She came to us by 9, realizing that this child is doing well. And you can look at her speech.
Hi, my name is Aishwarya. I received a cochlear implant at the age of 10 in Manoj ENT Institute in 2008. The cochlear implant has allowed me to improve my hearing and to improve my.
See, you do not want to hear this, okay? This is. It actually pains me to listen to Aishwarya's speech. You don't want. You need to see. This is what happens when you implant late. I mean, these are not deaf children. They are only partially deaf, and still with all that, their speech is so poor.
Hi.
Now, but how do you get these children very young? So you need to test them extremely young. You need to have hearing assessment like infant toddler meaningful auditory integration scale in a little years assessments. You need to have age appropriate speech test, developmental assessment. You need to test not the BERA. I mean, BERA alone is absolutely useless. And then you need to counsel them, give them realistic expectations and commitment to therapy. They have to understand that you cannot have surgery and then have therapy in a weird place. They need to be in a good place for therapy, and the support system has to be good. So what all do you need to do? You need to have behavioral observation, you need to have visual reinforced audiometry, you need to have condition play audiometry, you need to have emittance, acoustic emission, and ABR. Even if you look at the whole thing, ABR comes way down the list, and that's not really important. So people say that this child, I did a BERA and the hearing is profound, so I'm going to do an implant. That could be the most terrible thing to happen. I'll tell you why. Now, so what you need to do when the child fails the OA test, they need to retest 1 month later. If it fails again, go for detailed audio testing. However, if it passes, don't tell them the hearing is normal. Explain the methods of surveillance, and then 2 passes, They still need to be said that your past doesn't mean that you're normally hearing, but then it shows that there is no serious concern. So you need to be following up regularly. Now, if the test, there is midlear fluid, what happens if there is midlear fluid? Don't test hearing when there is midlear effusion. So when you do a patient that comes to you for hearing testing, first do the tympanometry. And the tympanometry is showing a B-type tympanogram. Don't go ahead and do a Barrett test because it will be terrible. So then you need to put in a laryngotomy, and you can do it in a very young child. This is a, 3-month-old baby. So you can do a laryngotomy and put in a grommet and then do a retesting. And that's very, very important for the child's ear to be healthy by the time you do an implant. I only a few days back, I had done an implant for a child who had a midlear effusion. It is a terrible mistake. I mean, the ear will be so difficult, surgery will be unnecessarily troublesome. But on top of all that, you may be missing the real hearing. I will tell you why this happens. So this is what we do. Infant presents severe hearing loss. There is residual hearing, yes or no. And then if it is residual hearing, do an aided audiogram. If it is aidable, then you convert them to a hearing aid. If it is not aidable, they have to go get an MRI done early, and there's an anomaly, yes or no. And if it's yes, you need a CT. If it is no, you need to go directly for CI surgery. And the hearing aid also, if there is no hearing aid benefit, they also go for hearing surgery. And the whole time frame for doing this should be 4 to 5 months. You cannot be delaying the whole, from time of diagnosis to CI, or time of diagnosis to saying that this child is going to do well with hearing aid, should not be more than 4 to 5 months. However, if there is a high risk child, you need to do a little bit more. So the profound hearing loss, need to do imaging. There's anomaly severe, you need to do a ABI. Not severe, and if there is no hearing aid benefit, a cochlear implant. If there is hearing aid benefit, milder hearing loss, you need to test and then go for a hearing aid. So it all depends upon what kind of a hearing loss a child has got. If the child has got a high risk of hearing loss, which I'll come to later in my talk, they should not be going for OAE testing. They should go for all these things, including an imaging very early. I'll give you some example. This child, 9 months, come to us, is a neonatal AA, BR and OA refer in both years. It's got a LSCS baby, birth weight is good, no incident, the child is babbling, eye contact is good, 9 months. So we said that bilateral ME, and then we did a course of steroids and did a repeat tympanogram in 2 weeks. This was the refer, and a refer, they said the child is deaf. But when we did the hearing test, even though the child was B, so we did a bone conduction audiogram, and this showed only 35 dB loss, and after the midlear effusion resolved, the child has normal hearing. This is why you should not do a BERA test when the child has got a midlear effusion. Now look at this child. This is 2 years old. They had a birth weight, a neonatal jaundice, phototherapy, 1 week in ICU. Neonatal OE screen was pass. There was no developmental delay, diagnosed having profound hearing loss, hearing aid in therapy for the last 5 months. Can you imagine? 5 months, 2 years. And the MRI showed no anomaly, nerves are okay. And when we did the condition audiometry at 2 years, can you see that? There is actually a lot of residual hearing. I mean, this is what you should be doing. You should be having a method to do a condition audiometry at those very early age, 1.5 years, 2 years of age. You can actually plot an audiogram in those children. So you get a frequency specific graph. These are children who go to people who give hearing aids and say that, oh, child is hearing all right, 60 dB is more than the sound that I'm talking. But unless you get your hearing over here, the speech will never be normal. So this child has to go for a cochlear implant. I'll show you small videos how conditioning matters. An audiologist has to be sitting here. This is my audiologist. There has to be audiologist inside with the parent, and you can hear some sounds, and the child is actually placing the peg on the pegboard on hearing sounds. If you listen very carefully, you hear the sounds. I'll play this one. You can hear one ping, one sound. The child is trained how to do it. It takes a few days of practice before you can teach a child. See that sound? Child places it there. One more. See, sound, child places it there. So you need two good audiologists. You need an audiologist inside, you need an audiologist outside, and the audiologist outside plays a sound, and this audiologist trains a child how to do conditioning. It is not easy, and it can only be done with the best of audiologists, but it is possible if you really put your mind and heart to it. So what you do after all this, you need to have a surgery, and like I mentioned above, good surgery, surgeons should have more than a 98% success rate, which means only 2% of them should have complications. And you need to activate them very early. And if they activate it before 9 months, they achieve more auditory skills by the age of 4. See here, we do a very small incision surgery. So the incision is only just about the size of the implant. We make to a small periosteal flap, which is retracted anteriorly. And then we make a tunnel for the implant. And this is an older generation implant. So we actually used to make a receiver well and a tie down, which we don't do now with the thinner implant. So you make a drill out this bed, and then you place it in the direction of the bed, drill out the fan tail, and you make 2 holes for the suture to pass. That suture is made up of ethibond, and then you do the mastodectomy, posterior tympanotomy, and you make that electrode path, put in the electrode implant there, tie it nicely, and use the fine forces to insert the implant. And then after that, you close the periosteal flaps. The surgery is only complete when the periosteal flaps are airtight. It has to be so good. And then the skin incision. So when you do with such a small incision, the advantage is that you can actually switch on the patient the very next day. Now for the last 1 year, we've been doing the same next day switch on, which means surgery today, the child is fitted with the cochlear implant the very next day. And of course, you don't do it immediately. You need to do it only after your practice has grown and you're doing a few hundred implants. So they activated, and then at 1 month, we do a ESRT. ESRT is electronic stapedial reflex testing. And 3 months, you do the speech perception, and at 6 months, you assess the outcomes, and then you keep on testing them every 2 to 3 months. Because this speech perception at 3 months and outcomes at 6 months post CI can only be linked to a continuous use of hearing aid. And if the more they use, so we have today's implant will have there is a log inside. So you can actually connect the implant to the computer and find out how often the parent is using the implant. And that's very important for you to find out whether this implant use is being regular. Surprisingly, a lot of parents, because the child is crying, don't use the implant regularly. And one of the reasons for the bad outcomes could be because of that. So you need to have a patient care navigator. So we have 3 people in our department. Of course, our implant population is high, which is why we are having that. So these people, what they do, they call up the parent, they schedule the visits, they find out what is happening, they track the developmental milestones, and if there's any call, anything wrong, they are immediately calling these people who are round the clock available. There's on one WhatsApp number, and they actually call. So I get sometimes a message, so this parent is saying there's some redness, so there'll be a photo which is sent to me or to my assistant. So we'll immediately call them and find out what is wrong. We tell them to go to the nearest ear surgeon, and then they call us. So the whole system works from the time you implant till they are much, much older. So even today we get patients who are 10, 15 years post implants calling us up because there is a particular issue that they need us to look at. So you need to track their development. So you need to track them across stages. So once you do the implant, I think about 10% of work is done. So you need to find out, are they going to school regularly? So we have meetings with these parents every other month. I go there and I talk to them and find out what is wrong with them. Is there a family issue? I mean, sometimes you'll have a family is not supporting the mother in doing therapy. So we find out whether therapy attendance is good. And if you do it all right, so you can understand that all of your children will not do well. It's something that you understand. Say everything perfect. So imagine that everything is perfect. Your children, 88% of them should reach age appropriate speech outcomes, which means you do 100 children, 88% of them should be having speech just like a normal child going to a normal school. I mean, there are 12% will have so many issues. There'll be children with multiple handicaps. There'll be children with anomalies of the cochlea, thin nerves. There'll be children with developmental disorders. There'll be an occasional patient who's come to us late like Aishwarya. But in spite of all that, if you don't get 88%, you should look back at your program and find out what is wrong, which means 88% of your children should be speaking like normal children. And for that, you need to have a lot of things, including family engagement and optimal gains and early implantation. See, now here, this is a mother who's actually sending a video from home. This is not our therapy center. It is again in Malayalam. So there is a series of cards that are kept here on the pillow, which shows the story of the hare and the tortoise. All of you must have heard the hare and the tortoise did a race, and then the hair was so, proud of his own speed that he lay down and sleep, and then the tortoise overtook him. So the mother is actually asking the child to pick up which part of the story that is going to be done. So this is again, the therapy is not happening here. Therapy is happening at home, but this is being monitored by our therapist.
Halima, മുയല് അല്ല മുയല് ആമയെ കളിയാക്കുന്ന കാർഡ് എടുത്തതാ.
So just asking that which place does the rabbit make fun of the
മുയല് ആമയെ
of the
കളി
so she shows that. So that's a card where
പിന്നെ
hare is making fun of the
അടുത്തത്
tortoise.
ആമ മുയൽ ഉറങ്ങുമ്പോഴേ ആമ ഓടി മുന്നിലെത്തുന്ന കാർഡ് എടുത്തതാ.
So you're asking that when is the tortoise running faster? So the child is being now said that no, you're a bright girl, you're doing well, and all these things are important. So these cards are not placed in a chronological order. They kept randomly. So the child has to understand what is being taught to her, has to look at the picture and find out which is the correct picture. And all these are important. It's not just you should not have just a therapist sitting there and then forgetting about this. So therapy happens at home. Video recording is sent to the therapist to assess it and find out if they are doing well. These children are already doing well, but you need to have a complete progress report from them. So this is the infant, and this is the toddlers, the preschooler, school age. So your care for the patient doesn't end with your therapy time of 2 years or therapy or your surgery, immediate post therapy. It goes on till the child reaches school, college, and on and so forth. So you can see this is what happens when you get children like this. Now we did an assessment. Our children, I think 86 to 88% of them had age appropriate speech development. You can see how they are talking.
Hi guys, I'm Malavika. I'm from class 11, science stream. I'm now currently in Kollam. I got the implant at the age.
So this is the other one. There's another boy. He's now playing for Kerala Blasters football.
Good morning, everybody. My name is Samir. I am from MTB. Today I'm going to talk about the national game of India, hockey. To succeed in the hockey, you need.
Now you realize one thing. Why I want to show that he actually said to succeed, and then first he pronounced it wrong. And because he was hearing well, he went back and corrected that pronunciation. Because we also sometimes when we say something, we say it wrong and then we go back and correct. That happens only when your hearing is so good that your brain is able to find out what you spoke and immediately corrects. And all this happens because of sustained effort. It doesn't happen just by doing an implant well or just by having some therapy over the next few months. So to get children like Malavika and Zamir, who are actually brilliant people, if you talk to them, you'll never even realize that they are deaf. So you need to have family-friendly group sessions. We have group sessions, we have play activities, peer support and parent networking. Most of our parents are on a WhatsApp group and they are actually shown how to do an implant. Sometimes they say that I'm not able to fit the battery, so we are sending videos to them how to do it, and we facilitate them and support them throughout their lives. So it is like this. So this is how it works. So we have sessions where they all sit together and we teach them how the implant is being used and all that here. So there's a quality metrics dashboard. So age at implantation has to be high, surgical complication has to be below the 2%, speech perception outcome should be 85%, long-term device should be in the range of 63 to 96%, vaccination has to be good. They should have an 8.6 hours minimum of average daily wear. How much they are using an implant. The language development should be 63% by school age, and family satisfaction should be 92%. Of course, there are 8% people who are never happy with everything, but you need to have it in the low 90s at least. Now, how do you keep your surgical complications low? This is the next question. So, okay, I don't think that we should get into a discussion about which is a better surgical technique, a posterior tympanotomy or the Varia. But I generally do only the posterior tympanotomy. So do 99% of surgeons worldwide. I'm not talking about India, because we believe that if you do it by retaining the canal wall, don't go near your EAC skin, there'll be far less complications. But how do you learn to do a posterior tympanotomy? you should be practicing this in other diseases, not on a cochlear implant. I'll just show you one very tiny video on how we do a posterior tympanotomy in a patient with a tympanic paraganglioma. So similarly, you can do the same extended facial research for many things. You can do it for cholesteatoma, you can do it for tumors, you can do it for foreign bodies. Same incision like the small incision. So this is what you do. Can you see that? So you have this very large posterior tympanotomy right over the facial nerve, and all my juniors are trained to do this before they actually do a CI. So by the time they come to a CI, they are experts at doing posterior tympanotomy. So if you don't do a posterior tympanotomy, no CI. So you need to, your surgical complication rate when you do a posterior tympanotomy without a mastoid canal fistula or posterior canal damage has to be that good. So it is much more difficult to do a posterior tympanotomy in a cholesteatoma or a paraganglioma than in a cochlear implant. So if you can practice on something like this and be that good, that is when your surgical complications for cochlear implant will become much lesser. So we actually audit our failures. So this is a bit by 2018 is a very old audit. I mean, the next audit is going on. It takes a very long time to compile this. So we had about 200 odd, 1,300 implants, and the complication rate was 2.3%, which also included soft failure. So, I mean, if you take out that soft failures where the implant fails because of a company issue, it is maybe less than 1.6%. So we had patients who had post-op infection. This was very early days. Now very little delayed implant extrusion to the canal. This was an anomalous year. We had a delayed wound infection, so we had explant and reimplant. Impending exposure happened in number 6 and 8 patients. So we did rotation advancement flap and salvage implant. Once it exposed, there's nothing that you can do. These were trauma. The patient fell and broke the implant, so we reimplanted them again with the good outcomes. There was a patient with cholesteatoma, which we explanted, repeated blind sac closure and reimplanted, a better outcome. Discharge, so we had to do a cartilage tympanoplasty. So far, so good. There were 2 patients with temporary facial palsy, full recovered in 3 months. One patient went down and had an implant the other year. And this was again early days. Nowadays with the facial nerve monitor, we don't have them. Some people develop seromas which need steroids. So including all that, 2.3%, it's not a bad failure rate. But if again, like I said, this is amplified because of the soft failure, which technically should not consider a failure rate, but is still failure all the same. So now, if you take that soft failure out, it is 1.3%. That is where your failure rate should be. So we also we have different electrodes now to, so this is where we are actually exposing the round window, and you have electrodes which are designed to go directly into the middle part of the scala, mid-scalar implants, which actually preserve residual hearing. So now we are able to do surgery for, so this video which shows, it's not the real speed which you inserted. So you take about 2.5 to 3 minutes to insert the electrode. And this is supposed to be done for children with a lot of residual hearing. Why we get good results in those children is because when you do surgery, you're not supposed to destroy any residual hearing in the cochlea. So what is this performance? How do you assess that you have a good program? So what is a referral to diagnosis time? A child comes to you with the suspicion of hearing loss. They say that the ideal benchmark is not more than 5 weeks. I already told you about this. And diagnosed to surgery time should be about 3 months, ideally. So 3 months they have diagnosed. By 6 to 7 months they should be ready. We do implants regularly at 7 or 8 months of age. They should have a very high ABT attendance rate. There should be early intervention requirements. School support should be good. Parent training has to be perfect, and family satisfaction has to be very high. So all these are the metrics by which you can decide whether you look at them every now and then, and you say that each one of them, are my children getting surgery early? Is there a lot of delay before surgery? Is the ABT therapy sessions being attended regularly? And you should look at them. See, so you need to have pediatric audiologists aligned to caseload. See, it doesn't, if people say that I did 100 implants last month and all that, it's terrible. It's not a right thing to do. In my center, we say that between 10 to 15 implants a month is a max that we can go with 8 audiologists and 8 habilitations. So you need to have these people. So you cannot go and say this month I'll do 20 implants, and that's not a right thing to do at all. Therapy sessions has to be all these things, cross training, telehealth. If you have to do it right, you have to do only those numbers that are aligned to your team size. You can't have one audiologist and one habilitationist and claim to do 10 implants a month and boast about it. That's not right. So, see, we have this is one of the trips that our children took to one of the farms nearby. There's a activity with playing with birds and painting and some rides. So we have all these 1, 2, 3, 4, 5, 6, and this are not here, and this one. All are audio. There are some of them are mothers. This is our audiologist. This is another audiologist. So this is one therapist. So there are a lot of them. This is another therapist here. So all of them get together with the parents and travel with them and have these activities even outside our center. And for that, for you to do all these things, you need to have only that much caseload. I mean, that is which is why I don't like people who say that I have done 300 implants, 400 implants, and say that I have 2 audiologists. That's never right. So you only increase your team and then do that much implants only a month. This is what is most important. So how do you sustain it? So you need to have state programs. We have a wonderful program in the state which gives free implants, free habilitation, free spares, and free replacement support till the age of 25. If you don't have that, you need to have charity care equipment donation programs, family support group. We do have a WhatsApp group, so we can track. We always track the long-term outcomes. And once this is good, you should start an LCA program. It should not be the other way around. See, we did, say, I just want to show you the statistic. We did the statistic for the number of patients implanted in the state of Kerala. And this did not include my center alone. It included a lot of medical colleges and all that. So we found that the mean age of application, identification was 14 months, which is terrible. Age of hearing aid fitting was 18 months. So 14 to 18, 4 months lost in hearing aid fitting. They applied to the state cochlear implant program at 28 months. So 10 months delay between hearing aid fitting and applying. Age of surgery was 36 months. This is what we did when we audited the Kerala cochlear implant program in 2019. After that, we became very strict. We said that they cannot be delayed. So these children assessed when they were already some 3 years of CIUs, and we found that a large proportion of them were doing very badly indeed. So we found that they were all implanted by 3 years. You will think 3 years is a great number, but we looked at the outcome. We found that only 20% of them developed age appropriate speech outcomes. 23% to be very honest. So where is your right percentage of 80% and where is 23%? This happened because we audited our government program. And tell me which state in the country is auditing their government program? Zero. Nobody. And if you do it, you will realize what is wrong, and then you will do things that will be correcting. So this is what I said about sustaining. So you need to have an action plan. So you need to have a pediatric steering committee, family advisors, which is what we did with the government, age appropriate protocols and electronic health record templates, hire therapists, partner with early intervention programs, launch family education programs, and establish development outcome tracking dashboard that I mentioned. Because without all this, you will not get younger patients. Without all this, you will not be fitting hearing aids early. Without all this, you won't be having a good surgical result. So everything has to be good for you to do well. So you need to talk to obstetricians. The obstetricians had to be told that every child has to have hearing screening by 1 month. They fail, refer for full audiological assessment. Even if they pass screening, tell the parent that the pass does not mean normal hearing. The patient has to bring the child back for the slightest concern of delay in auditory development. There is a book which says that, if you don't see all these, you have to come back. And that has to be, the book is often given. There is a government book, but the obstetrician has to point out in that saying that if this happens, you need to come back for hearing testing. So they should be, if there is a child with hearing loss, to delay the next child till the child is normalized as much as possible. Imagine that you are a gynecologist and patient comes to you, obstetrician delivered the child, deafness. You should be telling the parent that now your child is deaf. This child will take about 4 or 5 years to normalize if you do early, and only then should you have a second child. And that's something that obstetrician should be telling. What should a pediatrician do? They should send all high-risk infants directly for full hearing evaluation. Even now, a lot of pediatricians in the country are only doing screening for high-risk infants. They ensure that every visit, child comes to them at 2 months with a cold, 4 months with a diarrhea. They have to be talking to the parent. Is your child having this much speech? And if there is a problem, refer immediately. You can take the slide and then show it to your pediatrician. They should ensure that immunization is given. Expect nothing less than normal speech with every child with hearing impairment. You cannot say, oh, the child is speaking, but that has to be normal. And they have to know about the risk factors of hearing loss. I don't have to tell you, you know what the risk factors are: low birth weight, Apgar score, low mechanical ventilation anomalies, hyperbilirubinemia, all that. Before they need to test all these people directly for hearing screening. This is not happening. I'm not joking. This is not happening even in Kerala. So I think it is a real serious thing. What should every doctor do? Every doctor has to ensure that every child born deaf has got a right to good hearing. Like Amriya said, deafness should not be an impediment to normal speech. Make sure the delay in intervention is avoided at all costs. I told you earlier, hearing aid fitting, decision to do a CI, 5 months. I mean, ideally they say 3 to 4, but even if it is 5 months, don't make the delay more than that. At 5 months after the diagnosis, the child should be said that you are a CI candidate. See, today the poorest patient in the country, in most states, and I'm not saying that every state, in Kerala definitely, and Tamil Nadu sure, Andhra Pradesh yes, many states have a government program. So the poorest patient can have a CI, but if you don't do that early enough, it is criminal to delay them. See, imagine there is a head load worker's child who's deaf. The mother has to work to make sure that the family support is there. You do an implant by 6 months. Anyway, the mother has got a small child not working. Then in about a year, the child is normalized. Then the mother doesn't have to struggle so much. She can go to work and things in the family will move on. But imagine you implant a child at 3 years. This mother has to be behind the child to 5 to 6 years. Is it possible for a poor family to spend that much time to do a habilitation program? Which is why we have poor outcomes in the country. You need to demand good outcomes. Every person here, every person sitting in this hall, even if you're not doing a CI, your child, if it comes to you for otitis media or throat pain or tonsillitis, you should say that your child will have good outcome if you do things properly. So we had this our Cochlear Implant Group of India National Conference in Calicut. This is my last slide, and where our children, these were all our implanted children. This was the girl who joined the MSc ENT. They did the presentation of the cultural program.
Our hosts that we have shared and our personal journeys with cochlear implants. Our theme today, listening, language, and literacy captures the essence of what we have experienced and continue to embrace. Thank you.
Just like the management especially particularly the different components of qualifying. The harmony period of autonomy, the joyous celebration of open up, and profound spiritual meditation. Our lifetime story really to become.
This was my first pediatric cochlear implant. I implanted it in 2001.
Our ear to the sound of the wind and also even as the road to communicate our thoughts and emotions. Allowing us to actively engage in our activities and share our unique voices. Truly, we see the importance of listening. Truly listening to one, understanding different perspectives, and celebrating diversity. Languages and linguistics are not just about words. They are about function, expression, and the ability to convey our experience. Our journey demonstrates that with the right support and technology, barriers can be overcome and every voice can be heard. As we lead you today, we immediately appreciate the beauty of communication on its forms. Let's continue to support each other, celebrate our achievements, and strive for the moment. Express themselves freely and fully. Thank you for speaking.
So you need to understand that if you want to be serious about having a good program, pediatric hearing loss needs urgent attention. It's only when you diagnose early will you have a good program. And if you treat them appropriately, there'll be a good result. And for that, you need a team. So if there's anybody out there in the audience, young person who wants to have cochlear implants as something, develop a good team. Because without a good team, you could be the most brilliant surgeon ever, but your program is never going to be that good. What I said about your 88% good results. Thank you.
Thank you, sir. So we have a lot of senior ENT surgeons and cochlear implants who have joined in for the program.
Can you stop the sharing?
Yeah, I'll do it, sir. Yeah. So I open up for discussion and any participant unmute and have a word. So there were a few questions, sir, in the chat section regarding MRI and CT scan. So what is the sequence you follow and any
I actually did mention about MRI. What we do is that I did mention here, I didn't go into detail because it was not aligning to the topic that we needed, but I did mention. So if you find out profound hearing loss, the first test that you do should be an MRI. You should not go and do an MRI scan after you have posted them for a CI. That's not how it works. So imagine that you have a parent comes to you with hearing loss, and then you do all the hearing aid fitting, nothing is happening. At about a year, they get the government program, and then you do a scan, you find out there is no nerve. I mean, what will be your situation? I mean, suddenly you have to tell the parent that, no, I can't do an implant. Now, what is happening? If the child has got no nerve, they have to start, lip reading, skewed speech, and sign language much earlier. They need to have total communication. So you do an implant, you find out that there is a profound hearing of 3 to 4 months, do an MRI. I mean, you don't need to do a CT because an MRI will show you what if there is a nerve, if the cochlea is normal, if the brain is all right. That's all the information that you need. You don't need a CT to say all that. Later, when the patient is about to be having a cochlear implant, you can do a CT scan if you want. In fact, we don't do it. We don't do a CT at all. Because the CT is, they say that if you have a very experienced center doing more than 1,500 implants, you can give away the CT. But I'm not saying that even in Kerala government program, we do insist on a CT because not everybody is experienced. But for my center, we don't even look at the CT for doing an implant because we can do a post-tip anatomy. There is a facial nerve monitor. We know if there is a facial nerve. But if there is an anomaly in the MRI, we'll always do a CT. With a normal MRI scan, no CT is done. So CT, always the MRI to be done on diagnosis of profound hearing loss and CT just before surgery. Don't do a CT very young because these children have, very young children, if you radiate them, every CT, there's a risk of ionizing radiation and there could be a complication. There could be an early development of thyroid cancer, which is really there now. So don't do a CT on very young children. If there is an anomaly, MRI will show you there is an anomaly. But if you're doing an implant, do the CT just before that. Of course, one of the special situation would be meningitis, where you would like to do it early. But again, meningitis, much after ossification happens in the MRI, you will see it only much later on the CT. So there's no point doing a CT actually. So if MRI is clear, the CT will definitely be clear. So the message here is early MRI, CT just before surgery if you want to do.
Also, can you share a few points regarding the immunization protocol you give for your implant patients?
Okay, now if you ask me, see what is happening is that in Kerala, they are already having pneumococcal and hip vaccination. And that's all what we give. So every child already get that. So if they don't have it, a pneumococcal vaccine is given. So basically you need to give a pneumococcal vaccine and a hepatitis, the hip vaccine is already given. The meningococcal vaccine is not given. So it's a normal immunization protocol. And if you ask me offhand, because you tend to give it to other people to do it, my juniors will be better answering that question. But we have when the person is given a surgery, once we know that the patient is a CI patient, we give them the chart and ask them to show it to the pediatrician who will know what to do. But I think in Kerala, most children are already getting pneumococcal and hip.
So, yeah. So next question was Dr. Ram Adhikari is asking, kindly share some tips and tricks for posterior tympanotomy and cochleostomy in rotated cochlea.
Okay. Now, there is nothing called a rotated cochlea. Okay, I refuse to believe that there is something called a rotated cochlea. Now, if you, I think if you are seeing my face, so imagine that you have a patient with a semicircular canal in this direction and digastric ridge here. The angulation of the facial nerve will be between the semicircular canal and the digastric ridge. Now, imagine that the patient got acellular mastoid, the digastric ridge will be up. If there is a very cellular mastoid, the digastric ridge will be low. So, depending on that, the facial nerve will have a upward or a downward course. And strangely, there is no way you can really predict this on a CT. You will not know. You'll have to go inside and find out. So if the facial nerve is superiorly placed, you will find it difficult to look into the posterior tympanotomy, and you find your visualization of your round window is wrong. So what you need to do in a posterior, if you want to learn to do a proper posterior tympanotomy, the technique is to identify the facial nerve, identify the caudate tympani, and go between them. If you don't find it is clearly visible, you can thin the posterior canal wall. I mean, you can thin it to a very large extent as long as you don't rupture it, and then go there. I mean, in very difficult situations, we have had a very rare situation where you can displace the canal wall anteriorly without damaging the periosteal layer. Even if it is not seen, and I've never happened to me in the last 24 years, but I've had a call from one of the person who showed me the video. There's no way you could see it. You can convert the surgery into a blind sac closure subtotal pituitary and complete the cochlear implant, because if you damage the posterior canal wall, the child is surely going to get a cholesteatoma later. So the issue is whether your round window is visible or not. So there are 3 types of round window visibility. One, you look into it like I showed in the video, directly the round window is seen. Second, there is an overhang that is covering it off. Third, you don't see the round window membrane at all. So the landmarks for the round window, when you want to see, if you don't see it very clearly, one, it is about steppies, the oval window width below the oval window. It is also above a small little bony prominence that goes up from the hypotympanic cell to the cochlea. It is called the fustus. People who do endoscopic ear surgery are very fond of this word. So if you can see that bony thing, ridge coming from there and touching the promontory. Just behind that will be the round window. So all these things are difficulties how to visualize the round window, but basically once you do the posterior tympanotomy, you look into the middle ear, you should immediately be able to say what you're looking at. So this is why if somebody is serious about cochlear implant surgeon should go to somebody who's doing implants, see about 50, 100 surgeries, and see the different conditions where the round window is visible and where it is not visible, and find out how the surgeon gets around it. So for me, a very difficult round window and a very easy round window, the difference in time of the surgery is 5 minutes. So in 5 minutes, you can actually make a difficult round window easily visible. But of course, it is not there because I've been operating for 24 years, I can do it. But still, you should be able to visualize this from many surgeons and to find out how they do it. So I don't think a cochlear rotation is now an accepted term anymore. Nobody in the ENT circles who do significant amount of implants talk about cochlear rotation. They say that the position of the facial nerve will make the visibility of the round window difficult. I hope I have answered your question.
Yes. So one more question. 2 months baby with BERA and ASSR showing profound hearing loss. When should we do cochlear implant?
I hope that you are asking this question before I started my talk, okay? Because I already mentioned that you should not be doing a BERA and ASSR and making a diagnosis of profound hearing loss. If a patient has to have a temperametry, autoacoustic emission, BERA, ASSR, condition audiometry. So your child should be conditioned to find out if there are there's any response to a hearing aid. So that's what I said. So when you do that, you can start doing an implant. See, so already there is approval for implants from 6 months onwards. Many countries worldwide are doing. We regularly do 6. I have not done 7 months onwards. We regularly do 8 months. We recently did a 8-month-old bilateral. But there is no urgent need to rush and do it. Okay, so you need, once you're surgically good and you can handle these very young children, you can do it very early. But you should be aiming to do it before the first birthday. So that's a ballpark figure. So if you delay it by after 1 month, 1 year, your outcomes will start reducing. So if you, even if you find out at 2 months, you have to confirm. So you give the child is 2 months. Okay. You've done all the testing. Child is profoundly deaf. So what do you do? Give a hearing aid. The child is using a hearing aid, having therapy. The therapist will tell you, sir, the child is using a hearing aid properly in the right ear, not in the left ear. Then you will know which ear is aidable. So the child is getting benefit from the right ear, you implant the left ear if it is still profound. So both ears no benefit, you give the implant to the side which is having more benefit. So your choice on which side you do will depend upon how the child is benefiting from a cochlear implant use, from a hearing aid use and therapy. So these will take time. So even if you find out in 2 to 3 months and give a hearing aid fitting, don't fit a hearing aid by 2 months. You could be wrong because your electrophysiological measurements could be wrong when they're very young. By 3, you should be able to confirm. Give a hearing aid, observe them for another 3 months, and then at the end of period, you say that, okay, this child will need a cochlear implant. Then you can plan your surgery between 7 months to 12 months.
So how exactly is a hearing aid helpful in a kid with profound hearing loss? Totally there.
This is a very good question. I think this is the most important question that I'm answering to. See, there is nothing called total deafness. Okay, all these children will hear something. You should understand that a child is born with a cochlea, nerves to the brain, and an auditory cortex. The child is coming into the world will not have a functioning auditory cortex. The child would have heard nothing, which means auditory cortex is not formed. There is a cochlea, there is a nerve, there is a cortex. Now the child starts hearing the sound, and slowly the nerves will transmit the sound to the cortex, and the cortex will map the sound according to which frequency they are hearing. Now, if child is profoundly deaf and you don't give a hearing aid, there will be nothing happening between the cochlea and the cortex. So there is no child who is totally profoundly deaf. There will be some hair cells somewhere here and there working. So giving a hearing aid early will make sure that the channel is open. That between the cochlea and the brain, there is something going. And that will help your cochlear implant to work better. Number 1. Number 2, like I said earlier, if there is a residual hearing and you give a hearing aid, there is benefit from both ears, but not total benefit. You operate the better ear. If there is benefit from both ears and there is good hearing and response from one ear, you implant the worse ear. So that's how you do. So your choice of which ear has to be implanted will depend upon the auditory benefit with hearing aid. So however much deaf the children are, you give them a hearing aid, they will hear something. And that something is enough for the channel from the brain to the cochlea to the brain working and making sure it is the auditory cortex is bright. I see all of you are surgeons. You must have heard this story that a deaf child is being brought to you and they say that, sir, my child is very intelligent. Wherever we go, he will never forget the way. You know why it is happening? Because the child's visual cortex is taking over the auditory cortex. So visual cortex is more powerful. Many deaf children excel in visual arts. They are painters. They do graphic designing. Why? Because their visual memory is much better than our memory. Our auditory cortex is being scavenged by the visual cortex. And why does it happen? Because they don't use a hearing aid. So it's extremely important that a child has to have a hearing aid. So what we do is that a child is profoundly deaf. They come to us and you know that, they're not going to get better. So we don't make them buy a hearing aid. We have loaner hearing aids. So imagine that a patient child is used to hearing aid and they undergo a bilateral cochlear implantation. Most of them will say that, sir, we would like to give this hearing aid to a poor patient. So what we will do is another patient comes, we tell them, okay, see, you need a hearing aid. This particular parent will loan to you. You just have to give it back to them without any damage. So most of these things are recycled over time. So we don't, make them bear the brunt of buying a hearing aid, which is really very difficult for most parents if they're poor. But the rich people are told to buy a hearing aid and to give it to the poor people for use.
So next question is regarding BERA. So how do you, what is the value which you consider for an implant, BERA levels?
See, the standard BERA done in majority of the centers is called a click BERA. So what does a click bearer do? A click bearer will assess hearing only between 2000 to 4000 hertz, one value. Imagine a child has got a hearing loss like that, like a trough shape audiogram. The click bearer will be assessing the deepest part of the trough, which means that will show profound hearing. The other frequencies will be normal. So you need to do what is called a tone burst or a chirp bearer. I mean, this is if your audiologist is not doing it, make sure that they do it. It is being taught everywhere. They're just too lazy to do it. So chirp bearer, what we do is that we test hearing at 500 hertz, 1000 hertz, 2000, 4000, 8000. So you can actually get a bearer according to the frequency response. So when do you do an implant? You do an implant when the hearing aid, imagine that there is the ballpark figure. I mean, I'm not saying that this is the country thing. If you have hearing more than 70 dB loss in frequencies above 2000 hertz, this child will never develop normal speech with a hearing aid. So for that you need to have all the frequencies. How can you do a click bearer and say the child is profoundly deaf? So you do a tone burst or you do a condition audiometry and say that, okay, this child does not have hearing above 70 dB. I mean, less than 70 dB in frequency above 2000 hertz. This child will need a cochlear implant. So that's a candidacy. So you need to have any hearing that is less than 70 dB in the higher frequency, they will be good hearing aid candidates. This is why in the beginning of my talk, I said that if you are starting a program, first don't do implants. Get all of these 60, 70 dB children, give them hearing aid, they'll be fantastic. So the parent will come to me, sir, this child is doing so well. Why is my child not doing well? You have to tell them that 70 dB hearing aid will work. 85 dB hearing aid will not work. So you will need a cochlear implant. So early on, to make a good name for yourself, you need to implant those children who have residual hearing because they'll be much better. So when you are starting a program, make sure that you get those good candidates so that you're even if you do, you can do 3 good candidates and do 25 bad candidates and get a better name by the 2 good candidates. So you need to find out those children who are doing well, who have got good hearing thresholds in the lower frequencies, and they are the ones who do much better. So a BERA level, this is the criteria. So any hearing worse than 70 dB in frequencies over 2000 is a potential cochlear implant candidate. It's not always good. Then you do a condition audiometry, look at the aided score. So the aided score has to come within the speech banana. There's a speech banana. I'm sure that you would have seen it. So when you give a hearing aid, the patient has to hear 8000 hertz at 20 dB. They have to hear. So what is a 20 dB sound? You need to have like leaves rustling in the wind. That has to be heard. So if your hearing does not come into the speech banana by your aided audiogram, that is a child who needs a cochlear implant.
So one more question regarding transtympanic AVR in hypoplastic nerves. What's the role, sir?
I thought I didn't go into any anomalies in this talk, but see, if you have a patient, imagine the child comes to you with no nerve or a very thin nerve, and then you will want to do an implant. So what you do is that you do all the tests, and if you do an aided audiogram and you get good aided responses, see, any child with an absent or a thin nerve and a normal cochlea with aided responses, you can do an implant. It will be much better than doing an ABA, braced implant. So, I mean, listen to me very carefully. Normal cochlea, absent or thin nerve, but good aided audiogram. You don't have to go and do an transtympanic ABR. But if there is no aided score, that's 0, profound tone deaf, you cannot see a nerve or a very thin nerve seen, then you can do a transtympanic EABR and then look at the EABR tracings. If you get a proper tracing, this child has got a better chance of hearing with an implant than without. Those child will have an implant and don't go for an ABI. But however, if you don't get any tracing at all and no aided scores, that is child will go for an auditory brainstem implant. So it is done only when the decision is where you have a child who's profoundly deaf and without aided audiogram, the aided scores on audiogram. Those are children who go for transtympanic. If we have a busy practice, we probably send for a transtympanic EABR every day to our OP. At least 2 to 3 children who are profoundly deaf come every day. I mean, not all of them will need an implant. I would say profound hearing loss. Children with severe hearing loss come. I think we have ordered a transtympanic ABR 3 times in the last 1 year, and that's all we needed. The rest of them, we look at the ADL scores and decide.
Can cholesteatoma surgery and cochlear implant can be done in a single sitting?
I wouldn't do it. I wouldn't do it. Of course, we are talking about pediatric cholesteatomas are extremely rare in that age group. But of course, if it is there, I would always do a surgery, a subtotal pituitary blind sac closure in a profoundly deaf, wait for 6 months and do a scanning and non-AP ADW imaging, and then do a cochlear implant. But I mean, it's extremely unusual that a child of 2 years or something is going to have a cholesteatoma. 2 months will have a cholesteatoma. Very unlikely. But if you do have somebody, I would say sincerely, stage the surgery, because there's no way, you are not God. You cannot remove cholesteatoma just because you got eyes and a microscope.
So next question, does anterior tympanotomy help on cases of difficult round window using an endoscope?
And obviously it will help. I am paranoid about seeing the skin of the external canal, which is why, because we have all been trained that way. When we were starting implants, there was nothing called a Averia technique or something. So we are all scared of seeing the canal. But however, if there is a very difficult case, you can always do it. Though I have never done it in my practice. You don't have to. In fact, even the most difficult round window can be assessed without disturbing the posterior canal wall much.
Can you talk about reversible hearing loss in newborns? How is it identified and managed?
Okay, that's a good question. So imagine that there is a child who's come to you, who's premature, and diagnosed as profound hearing loss. You know what? We are very scared about premature children because sometimes there is something called an auditory maturation delay. I mean, nobody has ever put a finger on that and said, okay, this is auditory maturation delay. But there are children who come to you and who will think they are profound, and then over a period of time, they tend to have better hearing. There could be many reasons for that. One is that, when you're see, after all, when you do a Bera, what are you doing? You're giving sounds to the ear, you're picking up waves on the skull. What is happening inside the brain? Now, this is all calibrated to an extent of a normal child. So imagine that you have a child with a normal, so the EEG waveform is being picked up by electrode that is putting on the head, and that calibration minus the disturbance, as you call that EEG noise, is calibrated to a particular thickness and shape of an infant skull. So imagine that there could be a child who's got a thinner skull or a thinner skin or a more resistant skin. You may have a wrong reading. So what we always do is that when we get a premature patient, we are a little bit more cautious. So we tell them to come every month and do a repeat Bera and try to do a conditional audiometry. See, we have had cases where we have done a conditional audiometry when there are 4 or 5 months of age. So, and then, conditional audiometry is very difficult to cheat. I mean, a Bera could be wrong, but a conditional audiometry will never be wrong. So if you think that there is a conditional audiometry showing responses, Bera is not showing responses, we call it auditory maturation delay. And these children are told to wait a little bit longer. We don't charge in and do an implant by 6 or 7 months when it is there. So when there is a disparity, see, which is why I do say that we do all the tests. So everything has to correlate. The tympanogram, autoacoustic emission, ASSR, Bera, click Bera, tone burst Bera, conditional audiometry, visual response audiometry, all these have to correlate. If they are not correlating, you delay your intervention. So that's the reason why, it's not about, I think it is something both, some auditory maturation delay, some equipment compatibility. That's what is causing this problem.
So next question is regarding adult CI, sir. What is the role, do you do CI for the people with sudden SNHL when they don't recover after intra-implant?
Yeah, of course I've done. Of course I've done. I mean, we have done for patients who have had a sudden SNHL in 1 year. We have done for people who, I mean, I don't force it on them. I have done only one person for a person with unilateral hearing loss, but I've done a few people have had developed bilateral sudden SNHL. We have implanted some people like that. I mean, they all do they well. But meningitis is one condition where even if you do an implant, the outcomes will be less than ideal. So if you have an adult post meningitis, in fact, we have a patient coming up next week. If there is bilateral sudden SNHL, I'll be very careful in counseling them, telling that, okay, you will take much, much longer time to gain serviceable hearing than others. And strangely, so is otosclerosis. I think Sunil Matthews, I saw his name somewhere, his one relative we had done. And this man, I think it took about 6 or 7 months after surgery. You would think otosclerosis is a wonderful result, but sometimes it takes a very long time for them to develop a good speech recognition following post CI. So adult, see, there are a lot of ifs and buts in adult CI. Unlike pediatric CI, which is fairly well organized, you cannot really say how well an adult will do. And it's much, much more difficult than doing a pediatric CI program.
So, last question from my side, sir. A typical, atypical case scenario where a kid has a normal hearing on one side and unilateral deafness. Will the kid enjoy the implant if you do it?
See, this is something that we have been struggling for long, See, because we tell patients that, okay, your child has got only one hearing, but the brain is infinitely more powerful. The brain is even is able to compensate for no hearing from the other side. But if you want to develop binaural hearing, which means localized sounds and all, then you need to do implants very early. I myself have a few children who I know that they have been born with single-sided deafness, and they have all grown up to become adults, and they have absolutely no problem with unilateral hearing. They are so good, they don't even bother. In fact, many children are not even complaining that they have unilateral deafness. Acquired deafness is a very different thing. Unilateral deafness, I think by some reason the brain kind of adjusts. Now, because of that, it is very difficult for you to put in and say that you have to do an implant for your child. You tell them that you take a choice, do it. Because when you do an implant for a child with unilateral deafness, the other side is normal. The child is always going to prefer this normal ear. He's not going to prefer the CI ear. There'll be definitely be a difference. So then there is a chance the child can reject the hearing implant. So imagine that your child gets an implant for unilateral hearing loss, and that the child does not want to use it. The first blame will come on the doctor who tried to do it. Because the child will say, I did not ask for it. Who made you operate? And I don't want an implant. So these are questions, are ethical and moral questions rather than purely scientific questions. So, but of course, in other countries, people are doing. Another issue is that in our country, if you put an implant and the other people immediately ask, what is this? And the child will become very conscious. We are a very difficult society. We are not handicap friendly. It is happening in the West, but not to a large extent. Even when they are willing to accept the hearing aid, even when they know what is the problem, even though a lot of papers are there, but there are very few centers regularly doing hearing implants in children with single-sided deafness. So I think we have to be a little bit cautious. I have not done so far. I don't think I will do either, because the evidence is not so great. The children, when they have normal hearing on one ear and deaf ear, are doing so badly compared to the child. So, see, you can probably argue, what does the child wants a job? The pilot in India will require good hearing in both ears, and doing an implant doesn't change it. So, I mean, again, you probably will still be having a child who's got a problem.
One question by Dr. Mudit: why don't you do Varia technique?
Oh, I know. See, for me, frankly, I don't find any difficulty in doing the posterior implant. It's never been difficult for me. Second is that I don't like the external canal being opened, because I feel that if you see, might take your own ear. I mean, don't take my word for it. Put a swab inside your canal and take it and send it for culture. It will go pseudomonas. Every normal, healthy human being will have bacteria inside his canal. I don't like my implant electrode coming next to the skin thing. I mean, people say that bone intern and all that. And secondly, I've revised so many various cases, and that too by people who claim to be so good in that, and people who claim to have 100% fail success rates in Varia. I've had so many patients that I had to reoperate. So I am a little bit worried. I'm not saying that I have not reoperated patients who have done very posterior implantation. That's also I have done. It's not like we have not done that. But frankly, for me, a surgical time today when I do an implant is between 30 to 40 minutes for one side. So we do both sides together in about an hour and a half. I mean, what do I get by doing a surgery that is infinitely more difficult than what I'm doing now? It is the way I look at it, I see it. Takes more time. It's a bigger incision, and plus there is a chance of damage to the posterior canal wall and the chordae tympani. That is my reason. I mean, of course, there are brilliant surgeons who are doing very. I have no complaint about that. But as far as I am concerned, the primary advantage of this surgery is to keep so far away from the posterior canal wall. Number one. Number two, you're not touching the ossicular chain. Number two, there is zero damage to the chordae tympani. But for that, you need to be aware of anatomy. I mean, the Varia technique came because people are scared of the facial nerve, and we should not be scared of the facial nerve. I mean, any facial nerve we should be able to handle. We have facial nerve monitors. We have to do, if you learn properly, surgery properly, anybody who comes to me, and if you really we have a full-time temporal bone lab here. If you put a heart and mind to it, in 6 months, I can make you do a posterior tympanotomy as quickly as I am doing. I see if you go to the West, and there's nobody, Australia, I mean, they're all doing posterior tympanotomy. A very small proportion I'm doing I have no complaint about that. Probably I'm biased because I'm seeing, people who had a successful Varia will not come to me. But people who had a failed Varia will always come to me, no? So I'm looking at probably from biased angle. But I would not do it. Because see, for you to change a surgical technique, there has to be many things. One, your present technique must be faulty, which it is not. Second, it should take less time, which it is not. Third, there should be good long-term outcomes, which I have not seen. These are the reasons I don't do Varia. But I'm not so hard and fast about this. Is purely my own experience. It has got nothing to do with the technique in general. I'm sure there are good people who do it. But this is my opinion.
So last question of the day, sir. What if the hearing loss is completely neural? Is cochlear implant still useful? Sorry, I mean, this is
Okay. Now, when you say neural, I can think of only one thing that comes to my mind is called postsynaptic auditory dyssynchrony. So there is something called auditory dyssynchrony. So it is mostly presynaptic where a cochlear implant is useful. When you do a postsynaptic, the cochlear implant is not useful. There is also a condition called cortical deafness, where you could have a nerve, a cochlea, but no cortical level. So these are the purely the purely neural kind of deafness. Very unusual, but possible. So in those cases, the cochlear implants will be of low benefit or no benefit rather. If you have a purely cortical deafness, I'm sure that there will be no, but these are very, very unusual. They are seen extremely rarely. Postsynaptic auditory dyssynchrony is a condition where a person who's an adult patient who suddenly starts losing hearing will have multiple neurological signs, and you will say that they will have not much of hearing loss, but 0% discrimination. And these are people who are you will see the nerve, but the nerve will not be functioning. And these people, we would strictly warn them against doing a CI because they don't derive benefit at all. We have done and we have burned our fingers. I don't think it's the right thing to do.
Yeah, I think that's all for the day, sir. Thank you. Thank you for patiently answering all the questions.
Thank you. Thank you. So do tell me the feedback whether people found this interesting or not. Okay.
Definitely.
Thank you so much. So bye everyone. Okay.
Thank you.
I'll log out.